Thank you very much. I'm going to talk about three things, really. I'm going to do a little bit of an introduction about NHSX, because I'm conscious not everybody will know what this thing we keep referring to is. I'll give a few examples of how data-driven technology is starting to make a change for patients and for staff. And I'll tell you a bit about what my team in particular is currently focused on, and then there's some time for questions. So NHSX, a new team created in July of last year, bringing together teams from the Department of Health and Social Care and NHS England and NHS Improvement into a single team. Co-located, we have more staff in Leeds than in London, but there are two main bases. And the idea is that rather than have slightly fragmented policy in one place and delivery somewhere else, bringing those things together to make things more effective and, importantly, accelerate progress. So NHSX now is leading the development of a strategy, program and project delivery in one place, working really closely with a range of partners, but the most significant of which is Nhs Digital. And this is our mission, making sure that citizens and staff have the technology they need. Very simple to say, really, really difficult to deliver. Speeding up the delivery and adoption of new technology. Helping people stay well and manage their health and care needs, and giving health and care staff the tech they need to do their jobs properly. We've committed to a forensic focus on user needs, and creating an environment that supports and encourages innovation. And that last one is one of the areas that my digital innovation team particularly focuses on. And we have a number of priorities, but here are a few key ones. Setting standards to ensure that all new NHS technology is interoperable. You might have seen that we did a joint letter of support recently to manufacturers of diabetes tools to say that interoperability was absolutely key. There's a fantastic blog from Diabetes UK in support of that came out yesterday. Publishing APIs for key national services. A really nice example of this is Nhs Login. So Nhs Login was built to be a way to authenticate people, to let them freely then into NHS Digital services. The main purpose it was developed for was for the NHS app. But it's been, through working with lots of digital health innovators as first and type, we've been able to integrate with lots of other products. And a couple of weeks ago, we're able to open Nhs Login as API as a self-service basis. This is really good news for digital health innovators. Authentication is tricky and it's time-consuming, and it's costly to develop. This is a wheel we don't think needs constant reinvention. We would much rather open up national NHS tools to the market, to the ecosystem, so that they can use it for good for more patients. So that, I think, is a really nice example of what we mean in that statement. Developing a structured and consistent approach for digital health innovators and partnering more fully with industry to leverage their capabilities. Having a new transformation model, what that means is that rather than parts of the NHS, say the cancer team or the mental health team or recently the team undertaking screening, have embedded team members from NHSX to help in the discovery and work out which solutions are the best. So it's a totally different way of working than has happened historically when those things were much more siloed. Enabling staff to access records wherever they are, the LICRA program, and also recruiting a world-class team to crack some of the toughest problems in the NHS and social care technology. You may have seen we've been doing a lot of recruiting at the moment. We've had huge interest in the directors of our missions, around 80 strong applications for each of those 5 posts. And we just announced last week our new Chief Technology Officer is David Turner, who'll be joining us in May. So we are busy pulling together the parts, both technologists and people who bring other really valuable experience to the NHSX team. And these are the 5 missions that you may have seen that we're focusing on. The first is around reducing the burden on our workforce. We know that realistically across the NHS, technology is often slowing people down rather than speeding them up. So we've got a lot to do to find ways that we can release precious clinical time to be put to other purposes. Giving people themselves the tools to access information directly is the key component of Mission 2. And then Mission 3 is that interoperability piece and joining up the data. The 4th is around improving patient safety, and the 5th around improving productivity. So that's all of our work is framed by those 5 things. I'd like to go on to give a few examples of how data-driven technology can make a difference. But first, I'll just tell you a story that somebody was telling me last week. They had spent the evening in a very busy, in fact, the busiest A&E in the country, on a wet winter evening. And they said, I really love this digital innovation stuff, but AI felt very far away from my experience that evening. And I have a lot of sympathy for that point. I come from an operational background myself. I am absolutely rooted in the real life of the NHS. But I think that if we select those tools that meet our most pressing problems, the opportunity is huge to make a difference in that A&E and in many others across the country. So I'm just going to give 3 examples of things that I think could have a lot of impact, just to give a flavour. So the first is a study that you might have seen in JAMA of a tool called Skin Analytics. This is an attachment that goes on the back of a smartphone, and they've just concluded a really big study of 7 NHS trusts led by the Royal Free, looking at mole images. So they're looking for early stages of skin cancer. And in the study, the AI tool was found to be as accurate as a dermatologist in doing this and successfully identified all the melanomas. Now, one of the interesting things about skin cancer is that if your skin cancer is caught at stage 1, you have a 95% chance of complete recovery. If it's at stage 4, that number drops right down. It's between 25% and 8%. And this tool was finding a huge number of stage 0 and stage 1 cancers, so the very earliest in situ stage, which could make an enormous difference to how people could recover. So that's just a really practical thing when we think that dermatology is right up there in one of the biggest specialties in the country. Dermatology, ophthalmology, these are very, very high volume specialties where if we can think about ways to help the clinician and help the patient, that's fantastically impactful. The second example, just going back to the chap talking to me about A&E, uses AI to help focus on the most important patients in terms of likeliness to attend an A&E department frequently. Now, many parts of the country are trying to do this. They're stratifying patients and giving them some input. But this is one of the most spectacular results I have ever seen. And it came out in the autumn. It's part of an RCT being led by the Nuffield Trust. What they found in York is that the cohort study of 1,000 patients compared to control had 34% fewer A&E attendances as a result of being stratified and then getting around 6 months of nurse-based telephone coaching. The purpose of the AI is to really refine the model, to choose the right patients, and to also be able to act really very rapidly. And interestingly, a number of other scores improved. So patient activation, well known to have a really strong relationship with how you use NHS resources. Essentially, the more activated you are, even if living with a long-term condition, the less likely you are to be a heavy user of NHS resources. So patients reported a big improvement in their health, their activation scores went up dramatically, and A&E attendances and admissions dropped really markedly. So I think that argument that these tools are futuristic and they are not dealing with today's problems, it is not necessarily the case. It may be that we need to prioritise those for which the NHS and social care has the most pressing demand. And then a third example, which just shows that data-driven technology doesn't have to be fancy to make a huge difference. The NHS spends £2.5 billion on agencies every year. And when people start putting in shift booking tools, which are loved by staff, they immediately save money because staff choose to work through the bank instead of via an expensive agency. And in particular, where they can pay them rapidly, staff satisfaction increases and propensity to want to work extra shifts also increases. Some of the satisfaction rates have been absolutely incredible, by increasing by 40% around staff retention, and with satisfaction rates rising up to 98%. And we would estimate that if every part of the NHS used a tool like this for booking its staff, it would save around £1 billion a year recurrently. So we're interested in all aspects of data-driven change. It doesn't have to be a particularly fancy, complex solution. For us, it needs to work on the ground to make a real-world difference to patients and to staff, and then we're really interested. So to say a bit more, that segues into the role that I'm doing now and the digital innovation team, some of whom are here, actually, and maybe can help me if I get any particularly difficult questions. So my new role since the beginning of July is to lead and set up this new function, which focuses on digital health innovators. And we haven't had that focus in a senior role before in a technology part of the NHS. So this is new and it's different, and I think it's really welcome. Also looking at how can we leverage better value from larger tech companies. We haven't always been able to have a relationship in that way. Often it's been with individual parts of the NHS. We're trying to get our act together a little better to do business with as an NHS entity. Working with stakeholders and partners, because there are a number of people who are really interested and care about this space and can offer practical support on the ground, including people like the AAC, the AHSN network, as staff across the NHS and social care, and also people in the charity sector that we're working closely with. We're supporting a number of demonstrator projects, and having the AI lab has really augmented that. And I also lead the communications and engagement team as well. And looking at the year ahead, it feels like 2020 is going to be a good year for technology in the NHS. It feels like we have a real mandate to crack on and do a good number of things. Reading the long-term plan, digital is woven through that as an expectation. It's no longer a niche, nice-to-have thing. It is becoming part of the mainstream NHS. We see that we'll be focusing very strongly in two areas in 2020. The frontline digitization piece, so digital innovations that save clinicians time, where we've got evidence solutions helping the system scale that much more rapidly alongside those partners I mentioned. And digital outpatients. You may know the long-term plan commits the NHS to a reduction in face-to-face outpatients of 30% over the next 5 years. We're helping lead the technology component of that work. And I mentioned right at the beginning this forensic focus on user needs. So we didn't want to just embark on a program of activity without listening to what people would actually like. So on the 4th of July, the week we were established, we held a major event with Tech UK, and we then held some opening listening over the next 3 months to ask digital health innovators what particular things they would like us best to focus on. Because there are certain things that are helpful to focus on at the national level. There are others that are better placed with other people. And we ran the event alongside the AHSN network, the Office for Life Sciences, the AAC, and Nhs Digital, to have all parts of the system in the room who could support innovators. And it was really interesting, and we have published the results of that listening in a report called Listening to Innovators that Lisa Hollands, my deputy, wrote, and it's available on the website. And I won't go through it in detail because time won't allow that, but just to say the 5 top themes were very, very clear and distinct. These were the 5 things that digital health innovators said, if you could just do 5 things, could you focus on these areas? The report talks about some of the work that we've begun to do in each of them. But if I just illustrate by talking to the point on procurement, So procurement can be really difficult for companies just beginning within the NHS. Sometimes the procurement rules that the NHS sets up, not on purpose, but inadvertently, can shut out people who are earlier stage. So we worked with the team at NHS England and Improvement to launch a new lot on the HSSF framework called Lot 0, the Innovation Greenhouse. It has different sets of criteria than the other lots. It's just been open, and I gather the response has been absolutely fantastic to the lot. It's being evaluated currently. But that was a way that we could just try to link some of the work we were doing with digital health standards and say that if you meet this standard, therefore it should be easier for NHS organisations to commission you. So we're just starting on that journey, but we're really pleased that we were able to, having done the listening in July, August and September, launch the new lot in October and to have it now closing in early February. So we're pleased to have something practical moving forward in the procurement space. There's lots we're going to do on the others. I was really personally very struck by the fact that digital capability that's in the system came up in the top 5 of digital health innovators. What they were essentially saying to us is it makes the most enormous difference. If I'm dealing with, let's say, an acute trust, if I have a clinical champion, if I have an operational manager who's not terrified of digital, this makes all the difference. So could you please focus even more on helping raise the game around digital literacy in the workforce? And you may know that there's a big program of activity called the Digital Ready Workforce, the Digital Academy is part of that, and we are increasing the investment in that in the year ahead in response to these comments. And then finally, to say a little bit about our work in AI, because it would be wrong to not mention it, but there's much more on this later on. We think the UK is uniquely placed with incredible ingredients, both in academia and in digital health innovators, both large and small, to really make a difference here and to lead across the world on an ethical, safe framework. We've been doing a lot of publishing about our thoughts. Hopefully you'll have read this fabulous piece, Artificial Intelligence, How to Get It Right, by Indra Joshi and Jess Morley and a whole bunch of other stakeholders in the community who've helped write this. Each chapter is led by a different partner. But that really states, alongside things like the Code of Conduct that we've also published, how we expect things to work in this country. We've been busy, as you can imagine, since the announcement in August, thinking about how to create the AI lab, and then last week announcing the award. And if you'd like to know more on this, do go to Sam and Indra's session. It's at 11:40 in this room, and it'll just take you through a bit more what we both have done to date and are seeking to do in the AI space over the next 3 years. I will stop now just to make sure we have enough time for questions, but these are contact points if anybody would like to have any further information. Thank you very much.
Thank you very much, Tara. I'll start the questioning, if that's all right. I was just interested about the nurse-based telephone coaching, where you said you had a reduction in patients then going to A&E. Given it was so successful in York, is there, or are there plans for that to be rolled out throughout the country?
So the RCT that the York study is part of has 7 hospitals in the group, so it hasn't fully reported so far, but it does look like the sort of thing that local commissioners looking at urgent care should really think through in some detail, because there have been many attempts at trying to reduce demand, none of which I can remember in my extremely long career, as you mentioned, that have ever actually worked. We've created new channels, but it's often surfaced unmet need, which is really important, but it hasn't actually helped people deal with their conditions. And I'm really struck by this statistic that At least 70% of the NHS's resources and time and energy are spent on the management of people with long-term conditions, and most of that is in the complications of disease. So if we could only help people at an earlier point, and if we could only focus on the people who need most help, it's maybe not surprising that we get results like this. So I think it's really encouraging. It's great that commissioners are making decisions to implement things like that locally, and it would be great to see more of it, yes.
Okay, thank you. Any questions, ladies and gentlemen? We've got a couple of minutes. If you put your hand up, we'll be able to get the microphone to you.
Let's see, isn't it?
There's a gentleman over here at the front. We've got two. Okay, we'll come to you soon. So we'll get that first question.
Hi. Yes, I'm on. Ago Forcella here from Oxford Immune Algorithmics. One of the things that's coming out from the conversations I'm having out there is access to patient data as well in terms of training AI algorithms. Obviously anonymized, but is that something that's been looked at as well by NHSX?
Yes, and it's a really big issue. How do we validate that algorithms are suitable for use within the NHS? So part of the AI lab is looking at regulation more broadly, and a radical regulatory incubator to align the regulation that we already have to best effect, and to think about how can we best have test sets for validation, and how do we move beyond the great opportunity that we have in this country for joined up data sets to something that's of real practical significance. One of the areas we've been looking at NHSX, apart from the AI space, is around breast screening, and we're going to hear today about some great developments in that field, but a number of the rate-limiting steps, it feels, are going to be having sufficient data so that we can test and understand what's going on. So yes, it is both an issue that we recognise and something that we've got in our sights with partners to do something about.
Okay, thank you. Gentleman here, right at the front.
Thanks, Richard Barker from the AHSN network, and congratulations on the momentum that you've been talking about, Tara. So let's think about young companies in this space. The NHS is a wonderful market, but it's not the only market. In fact, most aspiring young companies will want global markets. So speed with which they both innovate here, spread here, get paid here is really important. So I think you've mentioned a couple of things that begin to put that jigsaw puzzle together, the Lot Zero, the AAC, and so on. But tell us how fast you think young companies can get digital solutions to scale in the NHS?
That is quite a tough question, Richard. But I think there's reason for optimism that things are happening more rapidly than they were in the past. So some of you will know that there are a range of innovations, some of which are digital, that the academic health science networks across the country have supported. And over the last 18 months, the growth in successful scale of those products has been more significant than anything I've ever seen before. So I think we are starting to find ways to do it. Now, that's been helped by imaginative leadership from Sam Roberts and the AAC about targeting products and helping reduce some of the barriers. Sometimes those barriers are cost, but we find even making things free doesn't mean they walk off the shelves. But combining some incentives in the system with real boots on the ground support. Now the question is, can we scale up the scaling up? But I think we've got some good examples of tools that there is absolutely no way would have scaled in left to their own devices. HeartFlow would be a really good example. That was a couple of years ago virtually unknown in this country and is now in a lot of the big cardiac imaging centres across the country are routinely using it. So I wouldn't like to give a time scale I think it's really hard to say that, but what I would say to innovators is it's all about evidence. So the more that you can evidence, and it doesn't, cost releasing is always great, yeah, cash is wonderful, but it doesn't just have to be that. Genuinely saving clinical time. If your innovation is saving 25 minutes per shift per person, that's huge for an NHS that can't find a clinical workforce. We've got undersubscription of every clinical group other than pharmacists. So if we can save staff time, that's enormous. Patient benefits. So measure, evaluate, real-world test. And that is the quickest, that's, I think, the strongest advice I can give people who want to scale more quickly. Obviously, the AI award is an amazing opportunity for people who have products in that space, and I would encourage everybody who believes that they have a strong product, because we want the best in the world to succeed in this competition, to apply.
Great. Tara, thank you very much. Ladies and gentlemen, time is up, I'm afraid, so we're going to leave it there. But would you please give a round of applause to Tara Donnelly. Thank you, Tara.